Just a moment as people are joining us from the waiting room. If you wouldn't mind, use the chat and provide us with your name and your organization. We have some new faces today. Glad to see some folks who may be joining us for the first time. If you wouldn't mind using the chat and share your name and your organization. My name is Libby Sagara, and I'm with Blue Path Health. We facilitate the eConsult Workgroup, which is a project of California Healthcare Foundation. We'll get started just a moment. Thanks for those who use the chat and provide your name and your organization. That's super helpful. Glad to see some new faces today. We'll get started momentarily. We do our calls at over the West Coast lunch hour. We know we have a lot of providers and folks working with patients who join us. So we try to fit it in a time where you may not be seeing patients, but we know how busy you all are. Thanks, folks who introduced yourselves. Okay, just giving it one more minute as we let people in. Once again, if you just popped in with us, if you could take a moment and use the chat to introduce yourself, that would be much appreciated. This is Libby Sagara with Blue Path Health. This is the monthly eConsult work group. We are a project of the California Healthcare Foundation. We meet on a monthly basis to share best practices and also different states' approaches to eConsult. So we'll talk a little bit about that today. Thanks to those who are sharing their name and organization in the chat. And if you wouldn't mind just keeping yourselves on mute during our presentations today, we are going to open up to questions and answers after our presenters share their program overviews today. So just a quick agenda for those who are just hopping in with us. We'll talk just very briefly about what the eConsult work group is, since some of you are new to our group. The majority of time will be focused on our presenters today. This is a spotlight on the state of Washington. And our presenters, as you would have seen in our agenda, or if you get my communications, are Megan Quinn, who is Manager of Clinical Innovations and Project Core of the Association of American Medical Colleges. She runs a program that's nationwide that some of you may have heard of, and an organization that is part of AAMC's core program is the University of Washington. So our speakers from UW, I was going to say that's a little informal, but yeah, University of Washington Medicine are Crystal Kong Wong. Dr. Kong Wong is Associate Chief Digital Health Officer of Virtual Care Delivery. We also have Michelle Lin, Director of Virtual Care Delivery, and Kirsten Davenport, Program Manager for Asynchronous Capabilities at UW Medicine. Those who've just joined us, thank you so much for introducing yourselves in the chat. And I think without further ado, we'll get started. I'm going to hand to Megan Quinn from ANC to get started. I'm sorry, just quickly, for those of you who are new to our group, some of you may not have joined our monthly calls. So the eConsult work group, as I mentioned, is a project of California Healthcare Foundation. We meet on a monthly basis, and we've been doing this for about 8 years now, which is crazy for those of you who are veterans of the eConsult work group. We have been pushing for many, many years to support primary care providers and specialists who conduct eConsults. To make this a little bit more understandable to our patients with a real focus on the safety net. So we focus in California on our Medi-Cal patients, other states' Medicaid patients, and in terms of improving access to specialty care. So the majority of folks who are on today represent those organizations, whether it be FQHCs, public hospitals, Medicaid plans. If you are new to our group, you're in good company. Some of the services that we provide are our monthly calls that share best practices. We do frequent sessions on continuing medical education. So if you're a clinician and you want to learn more about eConsult, we actually do provide units for that. In addition, we have our econsultworkgroup.com website, which is sort of a repository of best practices and publications on eConsult from across the country. We have a monthly newsletter that most of you are probably getting, and if you're not, please let us know and you'll get on our list. And we'll talk a little bit more later today about our annual meeting, which we have done for 8 years. It's been great to see many of you in person, and we'll meet again in person this year in Sacramento on November 19th. So now I am really going to pass to you, Megan. So Megan, if you wouldn't mind just introducing yourself a little bit. I gave your title, but if you wouldn't share a little bit about your background, that would be great. And looking forward to hearing your presentation. Go ahead.
Great. Well, thank you, Libby, so much for including me today in the conversation. Thank you all for joining our call today. So as Libby mentioned, my name is Megan Quinn. I'm the manager for clinical innovations and Project CORE here at the AAMC. Project CORE stands for Coordinating Optimal Referral Experiences, and is a program that we've been leading now since 2014 to really support implementation of e-consults and enhanced referrals at health systems across the country. So today I'm going to share just some background on the CORE model. I'll highlight a few of the keys that we've seen to establishing a scalable and sustainable e-consult program over time. I'll touch on a few of the key policy updates related to e-consults over the last 5 years, and then just share some of the opportunities that we're hearing around opportunities for future scale and sustainability of e-consults. So as I mentioned, we launched Project CORE back in 2014, initially through a CMMI Healthcare Innovation Award. We partnered with UCSF Health on that project, who had originally piloted the e-consult model, and 5 academic health systems to really test the scalability and sustainability of the model. So based on the success of that program and really a growing interest in opportunities to improve primary care, specialty care, collaboration, and an increasing focus on e-consults as a strategy for that, we've since been able to work with over 55 adult and pediatric health systems across the country to support the program. And I see a few core participants on the line today, and had the good opportunity to work with the UW team when they joined Project CORE back in 2016. So across these programs, we've seen that e-consults and enhanced referrals have really led to access to timely specialty care. We've seen a reduction in referrals. We've seen high patient and provider satisfaction, and have seen a decrease in specialty utilization and costs. Go to the next slide. So the goals for Project CORE really are to improve communication, coordination, and culture between PCPs and specialists, aiming to improve timely and equitable access to specialty care, improve quality and experience for patients and providers, enhance primary care comprehensiveness, and ultimately control costs of care. Next slide. So the CORE model really has 3 major components, and I'll go through each of these just by way of background for those of you who might be new to this program. So the enhanced referral and e-consult that you see here are the 2 new tools that are built into the EHR at the health systems that we work with, really focused on trying to improve communication and collaboration between specialists and PCPs. And I'll go through what each of these kind of arms is in the next slide. The implementation strategy that you see at the bottom is really kind of the underlying tool that brings this together. So we've seen time and again that it's not just enough to put these tools into the EHR, and I'm sure you've all experienced this as well with your own programs, but that there really needs to be a focus on engaging providers and really establishing this culture of collaboration to lead to more standardization in care and really kind of robust uptake of strategies like e-consults. So on the next slide, you can see the enhanced referral arm. This is really aimed at addressing some of the challenges that are seen today around referrals, where often referrals lack a clear reason or clinical question. There may be misalignment between the PCP and the specialist around their expectations around co-management around the referral. There may be missing data. So the intent behind the enhanced referral is really to make a better communication between the PCP and specialist, and also to better tee that patient up for the first visit. So in the CORE model, specialties are engaged with enhanced referrals and e-consults, and they develop condition-specific templates that help to guide the communications for each of these. So with the enhanced referral, you can see that it includes, for example, some pre-referral evaluation management guidance. There's a place for a clear clinical question. It might signal relevant data such as labs or tests that are needed for that first visit. And there's also a place for a co-management preference. So this is where the PCP might posit that they're intending to refer the patient for a one-time consult, or maybe they intend for there to be some longer-term co-management with the specialist. So again, the goal again really is to have that improved communication and really try to tee that patient up for a best first visit. Many of our health systems have other broader referral optimization efforts going on as well, and access initiatives. And so we've been doing a lot of thinking about how the enhanced referral can continue to kind of support and align with those efforts. This next slide shows what the e-consults are in the core model. This will be familiar to many of you on the line, but in the Project Core program, e-consults are implemented in the EHR alongside of the referral workflow. So when a PCP goes to place a referral, as specialties become available, they'll also see the e-consult option. Like the enhanced referral, these include specialty and condition-specific templates. They are typically initiated by a PCP to designated specialist colleagues, really aimed at those kind of more straightforward, lower acuity issues that with the data available, the specialist can reasonably answer without seeing the patient in person. We've set up a 3 business day turnaround time in the program, though we often hear that specialists respond within a day or 2 to the e-consults, which is really important for the PCP and the patient to know they're going to have that timely feedback. And then importantly, if the specialist ever feels like the question's too complex, they can always recommend an in-person visit and convert the e-consult to a referral if needed. And then lastly, prior to the billing codes, many health systems set up an RVU credit or some way to recognize the PCP and specialist effort around a completed e-consult. So really recognizing the time and effort for the specialist to review the question and provide recommendations, and also for the PCP not only to place the question, but to also follow up on the recommendations. On this next slide, you can see kind of all the specialties that have been implemented across core health systems. You can see many of the major medical and surgical specialties. Most teams have implemented across both their adult and pediatric populations. We've seen some really good, interesting use cases too. Things like ambulatory pharmacy have been really successful at some of those systems. We've seen a lot of interest, as you can imagine, for e-consults in psychiatry and thinking about how those e-consults can support things like integrated behavioral health models. So a lot of really great use cases and discussion around some of the specialty-specific use cases for e-consults. Libby asked me to talk a little bit about some of the strategies that teams utilize to engage providers with the program. And I think one of the sort of important exercises we do with teams at the start is really think about what are the benefits of e-consults from various perspectives across their health system. And many of these key benefits, I'm sure, are familiar to all of you on the line. But again, just that increased access to timely specialty input. They really do promote that high value care, getting the patient the right care at the right time. The increased primary care comprehensiveness. We often hear about the learning that happens as PCPs engage more and more with e-consults. Patient and provider satisfaction, promoting healthcare equity. This is something that we've focused on in our core network, and I'll talk a little bit more about too. And then recently, there's been some more study around kind of the impact from an environmental perspective too. And our colleagues at the University of Colorado School of Medicine recently published a paper really quantifying the impact of e-consults as compared to face-to-face visits. And looking at things like eliminating mileage and fuel and time and pollutants that are associated with visits. So another kind of emerging area of study too, as we look at all of the different benefits of e-consults from multiple perspectives. So on this next slide, I just wanted to talk a little bit more about healthcare equity. We have a work group within our core network that has convened around healthcare equity. They recently published a guide on assessing healthcare equity within e-consult programs, and they're continuing to meet to identify opportunities to measure and assess how e-consults can really improve access to specialty care for underserved populations. Unlike telemedicine, e-consults don't rely on things like internet connection or comfort with technology. So some of those kind of traditional potential barriers to accessing care, because it is to provider, are reduced. We also had a group that looked at the use of e-consults during the COVID-19 pandemic, and they had found at the height of the pandemic that the e-consult percent specialty contact increased across the board, regardless of patient language and payer status. So I've included a link to that paper here too, if that's of interest to folks. I wanted to talk a little bit too on this next slide about just some of the key elements that we've seen to a successful e-consult program across our network. So coming back to that implementation strategy that I mentioned at the start of the call, these are really some of the principles for establishing a sustainable program. So really having guidelines at the outset for what is an e-consult and the elements of a high quality question and response. There's a lot of focus, again, as I mentioned previously, on the provider training and quality oversight, giving feedback where needed, and that process of iterative quality improvement. The templates, for example, are something that teams continue to iterate over time as they get feedback from providers. E-consults being broadly available to all PCPs and most specialties participating, we tend to see that there's sort of a tipping point where e-consults really start to become integrated in practice as more PCPs are using the model and more specialties are available. Clinician engagement is very key to developing the program and ensuring that it works well for both PCPs and specialists. And then finally, that leadership commitment to continue to scale and sustain the program. And that often involves having sort of a dedicated team that's really establishing the program at the outset. So I wanted to also touch on just a few of the key kind of policy updates. So over the last 5 years, we've seen increasing payer support to reimburse and scale e-consults. I think as many of you on the line know, in 2019, CMS did approve payment for 2 new CPT codes for interprofessional consults. Those are the 99451 and 99452 codes. CMS valued those at 0.7 work RVU each to the treating provider and consulting provider. We're seeing that increasingly commercial payers are covering the service as well. Another important update came last January when CMS issued a letter to Medicaid state health officials authorizing and really encouraging the coverage of e-consults in the Medicaid and CHIP programs. And that reversed a previous policy that hadn't allowed for the federal match because it was a provider-to-provider service. And then lastly, I wanted to highlight last June, CMS announced its new Making Care primary model, which focuses on primary care, specialty care collaboration, and really encourages the use of e-consults for advanced track participants. And that's a model that'll be happening in 8 states and kicking off this year. So lastly, just looking ahead, some of the topics and things that many of our teams are thinking about as opportunities to further promote e-consults are just continuing to identify solutions to facilitate e-consults more seamlessly across systems and practices. Many of our systems implement this program internally first and then are thinking about strategies for extending externally. Exploring kind of other high value use cases for e-consults, things like specialty to specialty and other use cases for e-consult. While many payers are paying, there are still a lot of work to be done around payer engagement and reimbursement. And then lastly, really thinking about how to incorporate and test e-consults in new value-based payment models. And I think the MCP program will be a great chance to learn more about that as well. So I have on our last slide here, just our website and my email if anyone's interested in learning more. I also included a link to our website on digital health and access to care. There are some additional resources here that might be of interest to this group. We've got an ongoing webinar learning series. We recently did a session on e-consults for pediatrics and rural populations that might be of interest. And we also published a resource recently on digital health equity and some best practices from health systems across the country. So just wanted to flag, this is another kind of hub for resources and webinars that are coming up that might be of broader interest to the group around digital health. So with that, I will pause and turn it over to my colleagues at the University of Washington.
Thanks, Megan. Just to note, we will get those links into the chat. So in case you all want to copy them over and take a look at them later, you can do that. We'll pause for discussion after we hear from our UW team. We went from broad to specific, having Megan speak about the national core program, and then we want to get on the ground in terms of what's happening at University of Washington. Just to note, Megan and AMC have been part of our work group for many years now, so it's great to see this program still going, and really want to hear some specifics around how this works and in the care settings. So I'm going to hand it over to the UW team. So Dr. Kong Wong, Michelle, and Kirsten, I'll hand it over to you. Go ahead.
Great. Thanks, Libby. Thank you for inviting us to speak this afternoon. As Libby introduced, I'm Kirsten Davenport, Program Manager for Asynchronous Capabilities. And then I'm joined by Dr. Crystal Kong Wong. She's the Associate Chief Digital Health Officer for Virtual Care Delivery, and Michelle Lin, who's the Director of Virtual Care Delivery. We all work for the Digital Health Office at the University of Washington Medicine. I'm going to give a brief overview of our eConsult program, talk about our current metrics, and then I'll share a few of our best practices. So a brief history of eConsults at UW Medicine. So we started our eConsult program in 2016 with 3 specialties for adult primary care patients. Over the next few years, we expanded to 13 different specialties. In 2019, we began billing for eConsults. During the PHE, we allowed all UW Medicine providers to order eConsults. And we piloted an external eConsult program with a partner site. Over the next few years, we continue to add additional interested specialties to the eConsult program. As of May of this year, we have completed almost 43,000 eConsults. Next slide, thank you. So this one is a look at our current eConsult specialties. We have 18 active eConsult specialties, 3 service lines that have turned off eConsults, although infectious disease is restarting eConsults in August, and then a look at 2 new service lines that will be going live in the fall. This is a look at our volumes of completed eConsults over the past 13 months. We continue to see an increase in the volume of eConsults ordered as the year progresses. In a later slide, I'll provide an update on one of the tactics that we use to help drive our eConsult numbers, which will explain why the volume increased. This is our volumes by fiscal year, and as you can see, we've had a significant increase in utilization of eConsults over this fiscal year. And the next slide. So using FY23 volumes, this is a breakdown of eConsults by specialty. So dermatology consistently has the highest number of eConsults, followed by hematology and endocrinology. This breakdown that you see here is fairly consistent year over year, although this fiscal year, we may see neurology break into one of the top 3. And next slide. So now I'm going to switch gears a little bit and talk and discuss how we've increased the utilization of eConsults at UW Medicine. So we have found that utilizing IT tools to guide ordering providers towards eConsults has been very successful. Over the past year, we have implemented a best practice advisory pop-up in Epic that appears when a provider places a traditional in-person referral to either dermatology or neurology. This pop-up provides guidance to the ordering provider, allowing them to either continue with the in-person referral or select the eConsult order instead. They don't have to exit out of the order, it automatically switches to the eConsult order. The use of this alternative selection pop-up has helped both dermatology and neurology significantly increase their eConsult volumes. And you can see an example down there of what we're seeing as the volumes have increased. And then another best practice that we found is having consistent training and feedback to the specialists working on the eConsults. We found that this is really crucial. We've implemented a requirement that all new eConsultants be trained by me currently on how to handle an eConsult. This ensures that they know how to correctly open an eConsult encounter, add the standard response template to their notes, and understand when it's appropriate to decline an eConsult. This training has led to fewer eConsults being completed accidentally, definitely a more consistent use of the templates, and less fear in declining inappropriate eConsults or those lacking proper workup. Additionally, we have found success with the QI work group that oversees the program as a whole, determining areas for improvement and outreach. We conduct a peer review program where we examine random eConsults to ensure high quality exchanges. Through this process, we provide feedback to both the ordering and completing providers and identify trends that may require attention. We've also found that maintaining a really good working relationship with the eConsultants has been instrumental in the success of our program. And I think that's the last slide.
That is. So, Kristen,
Hey.
since we have some time, I would
Yeah.
love to hear, before we break into some questions, perhaps Michelle, Dr. Kong Wong, you might want to share your thoughts on the program, some of your high-level learnings before we jump into some specific questions. So who wants to start, Michelle or Dr. Kong Wong?
I mean, I guess I'm happy just to start. Is there something specific that you want me to cover? I mean, I know you gave some
Just
food
love
for
it.
thought questions.
Yeah, sure. Well, we can jump into the specifics, but before we do that, just any observations in terms of the provider perspective. You know what, as a clinician, perhaps you can share some of your experiences, any lessons that you've learned coming out of the program.
Sure. I guess I would say probably the biggest observation is that, I think honestly, all of us are working in poor access systems, not just the academic medical centers, but especially in an academic medical center, we do have quite a long wait for, even just basic bread and butter specialties. So e-consults have been quite successful in helping getting a more timely answer. I think also it's, um, by design a high efficiency model where you're using your specialist's brain power kind of in the most effective way. So for those low acuity things, uniformly, just as Megan described, it's very well liked by the primary care provider. um, maybe a secondary thing that wasn't said in in either of the presentations is it's very good for education. There have been requests, and we haven't figured out how to do this yet, but there have been requests to create almost like a catalog of previous e-consults that could be searchable or use AI function, because so many of the questions are repetitive. There are kind of the greatest hits the specialists see for e-consults, and much of that management could be applied to other clinical scenarios. So, you may not even need necessarily a fresh e-consult. So that's something that, we've been trying to figure out how to do. I would say like the biggest issue with e-consults is the reimbursement and trying to figure out, is the juice worth the squeeze? Because again, in a low access system where your specialty time is very, very precious, how do you want them to spend their time? And I think, based on kind of older models of fee for service and, revenue driven models, on paper, it may seem like, well, your cardiologist could do an e-consult or they could see a patient. And obviously, for a fee for service model, that's much more money if they use that time to see a patient. And, our queue of referrals is so long anyways, like why would we ever pull them out of clinic to do something that's less revenue? And, that's really kind of an antiquated thinking process that we've had to kind of combat in many ways. I do think it's very difficult to show quote unquote value, when you've got a finance team that's very used to kind of just crunching RVUs and those types of things. But it's a fight that we're willing to battle, and we're trying to find creative ways to kind of make our point, that on the whole, these programs really do add value, even in a fee for service world. So that's my experience in a nutshell. I'm happy to answer some more specifics later about
Yeah.
details of the program.
We'll get into some more for sure. Thank you, Dr. Conlong. And before we get into some of the questions that are coming in, I'd love Michelle's perspective as your director of virtual care. Can you explain to us how eConsult fits into your bigger picture of virtual care? Is there some sort of handoff, or is there a flow from eConsult to other types of virtual care, such as live video telehealth? Maybe you can speak to that, Michelle.
Yeah, I mean, I think it's another access point for patients, another option that we can offer to them, that in addition to telemedicine, in person, that patients want a lot of different options. So this is just one more for providers. And as Dr. Wong mentioned, that there's a lot of access issues. And so this is an ability for a provider to be able to review a patient's case and be able to get that feedback quickly to that referring provider versus the patient having to wait for a long period of time. So it just gives patients and referring providers more options.
Yeah, that's super helpful. Thanks, Michelle. Dr. Conwan, you made a comment here that I just wanted to make sure we had clarified. You mentioned at the beginning of the presentation that some of the data, it says this was the AMC Project Core model. I'm guessing that you were just clarifying that the data were just specific to Core and not your larger telehealth efforts. So could you clarify?
No. It's just, the model that Megan described,
Mhm.
it
Yep.
was part of the Project Core rollout. So we partnered with the AAMC to design our program. So all that stuff about enhanced referrals and yada, yada, it's the way our program is. It's very cookie cutter from what the AAMC rolled out and is still rolling out.
That's helpful. One of the biggest challenges that we have in California, and other states are facing the same barrier, is how do you quantify or give credit to providers, primary care providers, specifically primary care provider, in their efforts to conduct e-consults? And you mentioned, Dr. Kong, that's one of your challenges too. Do you have any thoughts on how do you encourage primary care provider use outside of direct payment?
We actually have not had to encourage the primary care providers. It's been on the specialty side that has been harder to entice. The primary care providers will purely do it because it's the right thing for the patient, and because the alternative is I have to explain to a patient why the wait for dermatology is 9 months. So frankly, it's easier for me to take a picture and send one of these than tell them why they need to wait so long. We do, some providers who are in specific types of incentive plans do get it automatically attributed 0.7 RVUs. We do not bill out the provider code, and that is because when we were looking at billing for e-consults, which the specialists do bill, on the primary care side, from a compliance perspective, it just seemed very arduous to try to document all of the necessities to build a code. So for those of us who are on productivity incentive plans, there is this kind of automatic attribution that the faculty practice plan puts on for doing this work. But we do have providers who do not work in those types of incentive plans. They don't get anything attributed. It's just, you know, something else you do in the grander scheme of taking care of patients.
We do hear that a lot in terms of the burden of having a primary care provider document their 16 to 30 minutes of work. It's another step in the process, which is not always, in their minds, not always worth their time, which is challenging. Going back to some of the questions that we're seeing come in the chat, and I know you did provide an answer here, Michelle. So Lisa, who happens to be from UCSF, so we have another academic medical center question here. How does UW staff their e-consultant pool? Is this standard rotation for all faculty, staff, clinicians? And I think, Michelle, you were responding to that. Do you want to elaborate?
Oh, sure. And then Kirsten, if you want to chime in, that was just part of the best practices of what Kirsten mentioned about her training either one provider or a few providers from each area to respond to e-consults.
Yeah, and we really leave it up to the department to determine how they're going to staff. So you would see a wide variety depending on which department you looked at.
Yeah, that is interesting. And what we see in a lot of programs in California that are not academic medical center programs is that there is reimbursement for the specialists. So that may not be as hard to entice them to participate. But if you're part of an academic medical center and it's just another step in your referral workflow, then you have to share that work. And that's what we see across a few programs in California. And feel free to pipe in here, Lisa, if you have any other questions. Everyone is welcome to take themselves off mute in order to ask. Going to Joy Burkhart, and Joy, feel free to share a little bit about your background too, since you've been a participant for a long time. But Joy's question is, are e-consults most utilized for specialties where images are shared, which of course we see a lot in California in terms of dermatology and other image-based e-consults. You mentioned derm, neurology. We've heard that PCPs working in behavioral health may prefer a longer conversation. Given cases tend to be gray areas, not as much black and white, like with images in dermatology. And Joy, please feel free to elaborate there. Go ahead.
Well, thank you for the important conversation there. I know there's been at least one pilot here in Los Angeles with the use of e-consult for maternal mental health. And I'm, what I've heard, not specifically related to that pilot. I want to actually dig those results back up. But what we've heard sort of more generally, and this is just hearsay, not documented research, is that providers like OBGYNs who may be interested in screening for these disorders, if there's a lifeline, right, or a consultation option, out of the gate seem to tend to prefer to talk to someone live because the cases can be pretty nuanced and complex. And I was just wondering if that has also been your experience with psychiatry or perhaps, other specialties where, to me, it seems like when there's images, involved there. It's a little bit more straightforward with the e-consult. Just wanted to see if that's also what you all have found.
Sure. So let me break that into two questions because I think they're kind of separate. So one, from a mental health perspective, it's true that not all cases are appropriate for e-consult, but that's true for everything. And I think what's important for mental health e-consults and what we have seen is that it's really for compartmentalized small questions. You know, I tried this medication, it didn't work that great. My patient had side effects, or what's the next step for titrating this, you know, et cetera. It's not for diagnosis. That's one thing that psychiatry definitely does not think it's very easy to get from chart review. And it's not for complex cases, which is something that is key. You know, psychiatry tends to be one of our lower utilized e-consults at UW, but I think it's because we, meaning the primary care workforce, have a lot of other options. You know, there's a state-funded psych consult line that's available 24/7, so you can get someone on the phone. You know, all of us in primary care, you know, we're fortunate to have an integrated behavioral health team that's in our clinic. So you have other options, whereas for many of the other specialty, you do not have any other option besides an in-person referral.
Really helpful. I appreciate that.
Yeah. The second part of your question was about e-consults for like imaging only. I think it's completely specialty dependent, and I think it also depends on your specialist and just kind of their preference for what they want to see in person or not. We definitely have a lot of like quote unquote cognitive specialists that don't do anything with images or imaging. Like I think neurology is a great example, although sometimes you'll send an e-consult for like weird MRI readings. Like, can you just tell me, is this significant? You know, most of the time it's like headaches or it's, you know, seizure workup or something. And, you know, as Kirsten mentioned before, they're one of our service lines that's very strapped for access and actually requested the alternative selection because they really wanted more to funnel through e-consults, just because their queues, especially for headache clinic, were just, you know, they're never going to get to the bottom of that wait.
Mhm.
Really helpful. Thank you so much.
Joy, I wanted to pipe in on this note, you know, around mental health and e-consults. A lot of folks have been on our calls over the past couple of years, or we've spoken a couple of times on a program out of UCSF, Benioff Children's in Oakland, where they have a hybrid model of phone and e-consults. So like Dr. Kong Wong mentioned, e-consults most appropriate for routine and non-urgent questions, but there are some questions that are much more appropriate for phone. Or obviously emergent or in person. But this CAP program, I put the link in the chat, check it out just for an idea of how that handoff can take place, and a primary care provider can choose whether their question is more appropriate for phone or e-consult. So just wanted to share, you know, there are different ways of doing it, and that's an idea. Frankie copied in the links that you shared earlier, Megan. So if anyone wants some of their Megan's information from before, they're in the chat. There's a good question from Ray Pedden. Ray mentioned or asked, you know, if there's a reason that specialties drop out of e-consult, and of course we've heard, just like you mentioned earlier, Dr. Kong Wong, there are some specialties that are easier, or perhaps some questions that are more appropriate for e-consult. But is there any reasoning behind why you would not do e-consult for certain specialties? I don't know, Michelle, Kirsten, Dr. Kong Wong, who wants to speak to that one? Or Megan, are there any specialties that you see as done less frequently?
Yeah, I could say some of the common reasons that we've heard teams have had to sort of pause a specialty or take a specialty offline tend to be around just specialty bandwidth. They may have lost a provider, they just don't have the faculty to support it. So that's often a reason where maybe the volumes are just exceeding what the providers can handle, or they've had a change in staffing and they just are short and don't have the bandwidth for it. So I think those are some of the most common ones. Sometimes specialties will be sort of lower volume. And I think teams just tend to assess those as they go and decide if it's worth continuing to maintain and doing that quality oversight. Even if they get just a handful a year, is that still something that PCPs are using? So I think that's part of the kind of ongoing process around sustainability too, is just continuing to kind of monitor those volumes and decide for some of the ones that may be, used less frequently for e-consult, if it's something to continue to offer, just to Kristen's point about keeping the specialists trained and maintaining the templates and workflows over time. So those are just a couple comments I'd make, but I'll turn it to Dr. Wong too to comment.
Yeah, I agree with what Megan said. I mean, the reason for the 3 specialties who turned off e-consults was purely because of bandwidth. They just have a lot of competing priorities. I do think that there are certain specialties that certainly lend themselves more naturally, and typically those are your medical-based specialties as opposed to your surgical specialties. For our surgical specialties that are either live with e-consults or are considering them, they're really just slicing off the part of the pie of kind of the medical consults they do. These evaluations for procedures really don't lend themselves to e-consult.
Makes sense. This next question that came through is relevant to something I wanted to ask too. And we've heard from many primary care providers that just making time for e-consults is hard. How do you fit this into your day of nonstop back-to-back appointments? And so some have experimented with setting aside some dedicated time, like end of the day, give that primary care provider a block of time to conduct e-consults. And David's question, David, feel free to take yourself off mute if you wish. And I'll read it, but then please elaborate. I'd love to hear more about whether high volume e-consult specialists at UW are being given block time on their clinic templates to answer e-consults. As we've seen e-consults grow at my institution, it's become apparent that a model for this is needed to keep specialists happy and away from just answering e-consult during non-clinical hours, after hours, but it wasn't part of the core program. David, you want to elaborate on that?
Sure. Yeah, thanks. Yeah, I'm speaking to this coming from also an academic institution where we rolled out the core program in 2018. And, I feel like even though it's been many years, we're kind of in the stage of transitioning from like what I call maybe still a pilot over many years and building up the specialties to now, wanting full implementation, as it seems like University of Washington is doing. And what that means is, you might have, so I'm an endocrinologist. Endocrine is the highest volume e-consulted specialty at our institution every year. But at the same time, there's actually only 2 people in our division who answer e-consults. So there becomes a need not for, doing this during your admin time or after hours or on the weekends, but actually, convincing leadership that it is, and Dr. Kong Wong alluded to this, but blocking time in schedules, your normal clinical template to say, this is time to do e-consult work. And certainly the volume for endocrinology and a couple other specialties here have gotten to the point where I think we can start thinking about that, but I'm not aware of, that model existing at other institutions, although maybe it does, but there's certainly a need for it. So that's where that all comes from.
Megan, have you seen that in any of your other programs?
Yeah, we've had a handful of instances where, like you said, Dave, it sort of, you reach that at that volume where it makes sense to begin to protect some time. And it tends to be in specialties like dermatology is one that comes to mind. I think another institution in psychiatry, they sort of embedded it with some of the other work as part of their kind of broader IDH program. So I think we've seen a few instances where the volumes have been such that it sort of warrants blocking some protected time. But like you said, you don't want to sort of take away access inadvertently by doing that. So I think you have to sort of quantify what that tipping point is to be able to provide some supported time to do e-consults or broader kind of digital work. But welcome the UW's team's perspectives on that too.
Yeah, so we do have some specialties that give FTE, but that's completely dependent on their department or division. There's no, formula for FTE, but we are doing the digital health office at UW. We're actually currently undergoing an e-consult business planning exercise to try to have a more standardized recommendation. I'd say a couple of things regarding the providers who are getting block time. One, obviously, high volume specialties like derm, there's the volume of work will warrant that FTE. But for those that maybe either have inconsistent numbers or maybe too low numbers where it would make sense to allocate FTE, but they want to, have a sustainable program like ID. Actually, when they're coming back with FTE for the provider, but that provider is also responsible for other virtual care things that kind of help, I guess, like float the boat, I guess you could say, for e-consults. So I think that's more of the model that we're looking to suggest at UW, like rather than just look at e-consults in isolation, how do you pair that with other digital tools to enable someone to have maybe some remote FTE to do something else? And how do those numbers pencil out?
Great,
There's
thanks.
some good, oh, sorry, Dr. Saxon. There are some good comments coming in just on how it's been done at UCSF and other organizations at LA County. Looking at high volume, derm is obviously high volume specialty where you can look to a 0.1 or 0.2 FTE. That's what Beth and Lisa had done. Dr. Gibney, LA County, feel free to pipe in, Dr. Gibney. A few high volume specialty services, we've carved out time for specialists to do e-consult work. Specialists can reply up to 10 e-consults in an hour as opposed to seeing 2 or 3 patients in that hour. We see value in such reviews, even for patients who end up in clinic because they arrive better prepared for a definitive first visit with the specialist. And we're seeing that across your academic medical centers too, as it's a first step to the specialty referral. So pretty common there. Dr. Gibney, feel free to pipe in if you have any additional comments.
No, that's great. I was going to say I'm sorry to see that gastroenterology was not able to do some of their work from one of the presenters, because GI is our highest volume service line. And we find tremendous value in giving primary care doctors support around very common conditions like GERD, FIT positives, dyspepsia, inflammatory bowel disease, irritable bowel syndrome, all kinds of stuff. And so we actually, GI is one of the ones where we have actually carved out time for our GI doctors to do e-consults, because we see it as such, it's actually improving access. Even if I cancel their clinics, it's improving access because they are actually taking care of a lot of things that don't need to come to clinic at all. And then they are, for those patients, like I said, that do end up in clinic, the patient's already had a workup evaluation, and it doesn't take 2 visits to care for them. It only takes 1.
And on Dr. Gibney's point there, I think GI is consistently in like our top 5 of what we've seen across California, not just in academic medical centers, but when we see programs in FQs, so, outside in the community, in the clinic setting, we see pretty high volume GI also. So as we're nearing the end of our hour today, just would love to open it up to any final questions. If anyone wants to unmute, you're welcome to share anything with our UW and AMC team. Or comments. Dr. Saxon, do you have another
question? Yeah, sorry to dominate here.
No worries. No, it's fine.
I just would love to hear more from UW about what that engagement with specialists has really looked like. Meaning, is that meetings? Is it Zoom meetings? Is it in person? Is it newsletters? Like what in practicality does that mean?
Yeah. So I think maybe we should start from like maybe foundational things. So we've tried to make the DHO office in general like very accessible to UW medicine. So we're often getting FaceTime with the chairs, for instance. We attend the faculty practice plan board of trustees where all the chairs sit on it, and or make sure that the School of Medicine is very aware of what's available, what they can tap into, et cetera. And then we're also very engaged on the enterprise level, which is more like the UW medicine side of things. So executive leaders, service line administrators, just those people that kind of keep the wheels on the organization, have a lot of visibility and awareness of what we're doing in digital health. And because of that, when their own strategy may align with turning on digital tool, they know who to ask, who they can, even awareness of some of the specific things they could do. And actually something that Michelle and I do a lot of is meeting with, different, whether it's service line administrators or whether it's, chairs of departments or specific clinical leaders to just kind of talk about how digital health can help them achieve whatever strategy they have. So I think that's kind of foundational, is just having good communication and a good pipeline. Like many academic medical centers, like we cannot tell anyone what to do. We're a shared service. We're just here to help. Like no one's gonna be happy if we're like everyone needs to turn on e-consults or something. So you're just trying to be like the friendly, helpful person. They know who you are, et cetera. Once we have identified certain stakeholders that are very interested, engaged, and want to work with us, then it's kind of a conversation, right? Like what tools would they like to turn on? And then if it's specifically e-consults, then we have a very like organized program that they kind of tap into. Like Kristen's rolled out like 1 million of these new specialties now. It's very simple to design templates and do the testing and the training, and then we do rounding with the specialties at least once a year, where we go over kind of key metrics, and these metrics we share out on a monthly basis, so they're very, very used to seeing this dashboard. Kristen's a very accessible and friendly person, and so if they need changes to templates or someone new's coming on, et cetera, it's very easy for them to kind of just get in touch with her to help support the program. So, I just feel like we've got a good infrastructure for e-consults. So it's almost like, I don't want to say it's on autopilot, but it's very easy whenever we need to either turn something new on or, change something that's existing.
Thanks, Dr. Kongwong. I think it's so important to have someone like Kristen who is really leading that program and being the voice of the program, and also having that clinical champion like you to share that you are walking the walk and doing what you would expect those across your organization to do. But as we wrap up today, Megan, Michelle, Kirsten, any other thoughts on just engaging providers? Anything you'd like to wrap up with today? Great. Well, it's been wonderful just hearing sort of the broad to specific, what's happening in your multi-organization program, Megan, then and also how you roll it out in an academic medical center. So thanks for your time. We really hope to hear from you, and as your program grows, would love to have those updates. So thanks, everyone. Appreciate your time.
Thanks so much.
As we wrap up, I just have a couple of slides to share with you all. Most of the information is probably pretty familiar to you, but just to make sure we get this on your calendars, we have our November meeting coming up. Many of you were lucky to have had in person in the past. I know Sacramento is not central for all, but we hope at least central for many of you to be able to get to California if you're out of state and come join us in person. So we've been able to do this for many years with support of CHCF and our sponsors. Have the in-person opportunity to really hear how other programs are working, how other states have advanced policy and provider engagement, and just hear about our successes across the country and the growth of e-consults, not just in terms of provider use, but in terms of state policymaker support. So we'll meet again November 19th. Please do save the date. Thanks to our sponsors from the last year for really making this possible. In addition to our advisors, we have Dr. Giboney here today from Los Angeles Department of Health Services. In addition, Delphine Tuo, who's from UCSF. And it's been great to have these advisors really helping us to bring that voice of clinicians who are not only leading e-consult programs, but performing e-consults, as Dr. Giboney mentioned earlier. So just in wrapping up today, we meet either monthly or bi-monthly. We try to get everyone together either to share best practices as UW has done today and AMC, also to provide continuing medical education. But we often take a little bit of a summer break as people are traveling, many out of offices today with folks on vacation. So we're going to take a break for the month of July and see you once again in August. And thanks again for saving the date for November 19th. We look forward to seeing you again in a couple months. Have a great day.